Thank you for attending. So just before we start the event, I just want to let you guys know that for those who have registered for the breakout sessions, you will be immediately moved into those breakout rooms once the keynote is over and the discussion with that. And that for those who haven't registered yet for a breakout session but would like to, please just drop it in the chat box to Chelsea and she will move you into a breakout session when we complete that. All right, so I'm Supriya Mehta. I'm the Interim Associate Dean for Global Health at the School of Public Health, and I'd like to thank you for joining us. And so World AIDS Day was started in 1988, and it was actually the first public health day, global day. And it was started to raise awareness, to raise money, and to improve education, and particularly to fight prejudice, discrimination, and stigma. And so that, of course, is the topic of our World AIDS Day today, and it also aligns with the theme of World AIDS Day internationally, which is resilience and impact. So as noted by HIV.gov, the way that they have defined this is that the theme reminds us of all we can achieve together when we focus on impact by using data to deliver high quality, people-centered HIV prevention and treatment services to those most in need, tackling stigma and discrimination, and empowering communities. And of course, as we'll learn more from Dr. Ekstrand today, that stigma towards people living with HIV creates exclusion and isolation between individuals and in communities. And this creates barriers to support, care, health services, exclusion from jobs, places to live, places of worship, and many other institutions. So in keeping with this year's theme and the initial intention of World AIDS Day, we're very pleased to host Dr. Maria Ekstrand, who will be speaking on the role of stigma in the HIV epidemic. Dr. Ekstrand received her PhD in clinical psychology from Auburn University and subsequently completed an NIH postdoctoral fellowship in health psychology at the University of California, San Francisco, where she currently works as a professor in the Division of Prevention Science in the Department of Medicine. She is also an adjunct professor at St. John's National Academy of Health Sciences in Bangalore, India, where she mentors both US and Indian pre- and postdoctoral students. Dr. Ekstrand has been the PI or co-PI of 13 NIH-funded Indo-US collaborative studies. Her early India-based research program included the adaptation and validation of innovative measures of HIV stigma and treatment adherence, as well as cohort studies to examine prevalence and predictors of behaviors and clinical outcomes, including the development of drug resistance. Dr. Ekstrand built on and extended this work to the development, implementation, and evaluation of behavior change interventions targeting adherence to HIV regimens and the reduction of HIV stigma in healthcare settings. More recently, Dr. Ekstrand and her team have developed an interest in mHealth, and her partly computer-administered stigma reduction intervention is currently being scheduled for implementation across healthcare settings in Thailand. In response to the COVID-19 pandemic, she has expanded her India research program to include a sub-study of its impact on the management of HIV in India. So we're very excited to have Dr. Ekstrand with us today to talk about stigma and HIV. So thank you very much.
Thank you, Supriya. A lovely introduction, and thank you for your kind invitation for me to come and speak here. I so wish we could all be together in person, but as Tony Fauci says, the cavalry is on the way. So maybe 2021 will bring more opportunities for us to see each other face to face. So I will go ahead and share my screen now and see. Yes, it looks like it's working. You can see it? Great. We've all learned way too much about Zoom this year. So again, thank you for the introduction. And my name is Maria Ekstrand, and the research that I will be presenting, that's based on work we've done with my team. It's a very large team of collaborators, and I will be referring to them more later, but this is by no means just my work. It couldn't have been completed without lots of people putting in dedicated effort for decades. So given that it's World AIDS Day, I also want to take a moment and acknowledge people who started out this HIV prevention fight with us, but who are no longer here. Bob Hayes, Bobby Hilliard, Leon McCusick, Mark Gould, Chuck Frucci, and Randy Schiltz were all involved in the AIDS prevention response and documentation in San Francisco, and none of them are still here. The two panels that you see for Bob Hayes and Bobby Hilliard were completed with the input of several of us who were working with them at the Center for AIDS Prevention Study at UCSF, and we miss them every day. So my talk is going to focus on how there is no way for us to reach these goals without addressing stigma. And stigma was mentioned early on as the third epidemic, really, in HIV. And unfortunately, as we have progressed in terms of treatment and prevention, stigma still remains a major threat to our ability to attain the final goals. So in 2014, UNAIDS met and decided that between 2015 and 2020, we were going to meet the following goals. So they said by 2020, 90% of everybody who is HIV infected will be diagnosed, will know of their infection. And among those people who are diagnosed, 90% will be on antiretroviral treatment, and 90% of those who receive antiretrovirals around the world will be virally suppressed, which is the gold standard for treatment success. The next goal by 2030 is that we will have ended AIDS as a global public health threat. And different countries have set different intermediate goals. So here we are, 2020. How are we doing? My talk outline is going to is the following. I'm going to talk first a little bit about the progress that we've made towards these goals, how stigma is a barrier to achieving these targets, a little bit more about how exactly stigma interferes around the world. And I felt compelled to make a little detour given that we are now living through a different pandemic, and there's an intersection between the two of them, and COVID is both affecting the HIV response and the stigma that we're seeing. And then finally, I'm hoping to end on a more positive note and talk a little bit about encouraging developments in terms of preventing stigma from undermining the progress along the HIV testing and treatment cascade. So UNAIDS published these numbers in 2017 and called it the midterm progress towards the 1990 goals. And this is globally, or was globally in 2017. 70% of people worldwide who were living with HIV were estimated to know their status. 77% of those 70% were estimated to have accessed treatment, and 82% of those who had accessed treatment were estimated to be virally suppressed. But of course, there were a wide range depending on both type of population and region. And you can see here the regional differences reported in 2017, with, not surprisingly, higher income countries being closer to reaching them. But even within regions, there was a wide range with, for example, Botswana and Cambodia being very close to or even reaching their goals in 2017. So that's the problem. Whenever we try to summarize data, it masks some very important regional differences. But the chart would just be unmanageable if we put in every single country, obviously. So here's a year later, doing a little better. We're up to 79, 78, and 86% along the cascade. When you look at all ages, women doing slightly better than men, but in general, people were being very optimistic at this point. Again, looking at region, we're seeing similar regional differences with high-income countries being closer. And really the most encouraging finding, I thought, in 2018 was seeing how well Eastern and Southern Africa were doing, thanks in large part to great partnerships with institutions and NGOs in those settings, and the work of the Global Fund and PEPFAR. So 2018 was a good year. People were very encouraged. Then in 2019, we realized that things were not progressing quite as fast as they needed to if we were going to reach the 2020 goal. And this was pre-pandemic. We had no idea what was going to hit us this year. So people were starting to get a little bit more concerned at this point. So there are more obstacles than simply stigma. And I do want to acknowledge that resources and geographical differences, not even in terms of just high versus low middle income countries, but also rural populations versus urban populations, vulnerable populations versus so-called mainstream populations. All of that makes a difference. But even if you've made progress on all of those counts, there is still room for improvement. And I want to talk today about how stigma is acting as a very real barrier around the world to reaching each of these goals. So you remember the 3 points here that we are measuring is if people are getting tested, if they're getting put onto treatment, and if they are staying in treatment and adhering to it. So how does stigma interfere with this? Well, if you are afraid to go to a test site because you're a member of a stigmatized group, or because you are worried that somehow that'll force you to disclose your status, not surprisingly, you're less likely to get tested. If you are afraid that the healthcare facility, the ART clinic, is not going to keep your information confidential, or if it's located in a hospital with a big sign that says HIV clinic over it, you may be afraid to go in there because you don't want to be identified as an AIDS patient. So you delay going in for treatment. You may be feeling okay, so you may not really realize that it's important to get treated early. And even if you overcome those 2 barriers and you get tested, you find out you're positive, and you get your medication, if the people who live with you don't all know that you are positive, taking pills every single day and leaving your pill bottle around you is going to make it much harder to keep that secret. And if you're afraid, if you're afraid that you're going to be ostracized by your family, then maybe you do a risk calculation and figure, I'm still feeling kind of okay. I think I'll hold off taking this pill. Or when extended family comes over for a visit, or you have a wedding in the family, or a funeral, or some other major event where it's hard to get privacy, you may just skip your pill for a few days. And unfortunately, HIV is very unforgiving to people who forget occasional doses. and it's easy to develop resistance. Some people also tell us that they are afraid of getting the drugs at the local pharmacy because somebody who works there may know their family. I don't know how many times I've heard, oh, my brother-in-law's best friend works at their pharmacy. If I pick up my HIV medication there, he would find out that I'm HIV positive, and then he'd tell my brother-in-law and it would be all over. So people either don't refill their prescription in a timely manner and have a treatment interruption, or they will miss occasional pills, again, because of stigma. So antiretroviral medications are great, and they absolutely work and can end the epidemic, both in terms of the person who's taking them and their ability to transmit to someone else, but they only work if you take them. And if you're afraid of other consequences, then you may not be as consistent as you should be. So, how's that looking around the world? Well, as we can see here in this slide, there are studies all over in South America, in Asia, in Africa, in different populations, in women, in LGBT populations, people who inject drugs, who are scared to get tested and who don't do so because of stigma fears. And the interesting thing about fears is what you're afraid of may or may not happen, but as long as you are afraid that it will, that's what guides your behavior. So this is a very real barrier, and we need to better understand those fears and whether or not they are realistic and how to overcome them if we want to improve HIV testing and truly get 90+% in to learn their status. Okay, so how about the next step? Delay of care seeking. Again, we are seeing multiple studies from around the world showing that delay of seeking care is associated with various forms of stigma, not just feared stigma, which is a very real obstacle, as Laura Nyblade and her team showed in Kenya, but also having seen somebody else be stigmatized or discriminated against, which is vicarious stigma, or certainly having experienced stigma yourself, or, and this is particularly difficult to deal with, internalized stigma, which simply means that you have internalized all of these stigmatizing attitudes that exist in society. You may yourself come to believe that you are disgusting and dirty and that you deserve to be infected. And if so, that has very specific intervention implications. Also, criminalizing the behaviors that may have led to infection has a chilling effect on people's behaviors, both drug use or certainly selling sex. So initiating HIV care and treatment, unfortunately, yet another behavior that affects the treatment cascade, and that is influenced by stigma around the world. There was a qualitative study of pregnant women in Uganda that found that fear of disclosing their status was one of the key barriers to them initiating treatment. There have been studies done on multiple vulnerable populations, both globally and in the US. And there have been large meta-analyses and systematic reviews showing that this is a very real barrier around the world. And I apologize for going through this so quickly, but I think this will be recorded, and certainly if anybody wants to take screenshots or get a copy of the slides later, I'm happy to provide those if you want to look up some of these studies yourself. Okay, so people have gotten tested. They have initiated treatment in spite of all these barriers. How about adhering to treatment? And once again, unfortunately, we are seeing that stigma does act as a barrier to treatment adherence around the world. Multiple sites in Asia, our work being one of them, other research in China and in Thailand, also showing that HIV stigma predicts lack of pill taking and refill of prescriptions. Deepa Rao in Seattle showed that this is the case in the US as well. Multiple studies in Africa and Europe have demonstrated that non-adherence or suboptimal adherence is associated with various dimensions of stigma. There is another construct here that we find is crucial. So not only being afraid of stigma, thinking that you may deserve the stigma, having watched someone else being stigmatized, but the behaviors that you engage in to avoid this stigma can also make it much harder to take your pills regularly. So what we're hearing is people saying that, well, my neighbor asked me why I keep taking these pills all the time, and I couldn't really tell her that I have HIV, so I told her that I have TB. And oddly enough, TB used to be very stigmatized and still is in many settings, but in comparison to HIV, less so. But given how common TB is in many of these settings where we work, people generally know that TB treatment is only 6 months or 9 months. So it becomes harder after that initial time period to justify taking your HIV meds, since, as we know, HIV medication so far looks like it's going to be lifelong. Europe is not doing much better than Africa, Asia, or Latin America. Stigma is interfering with adherence there as well. So, as you see, there is a lot of stigma fears out there. So we thought we should look at, are these fears warranted? Because we all have superstitions. Maybe our worries aren't really, there's no basis for them. So several research teams did studies around the world and looked at, for example, healthcare providers, because usually people are afraid of stigma, either in their families or from their healthcare providers. And unfortunately, they are warranted. So we found that in Thailand, in Ethiopia, in India, stigma was real. And this is from a study that our team did in 2 large metropolitan cities in India, in Mumbai and Bangalore, where we interviewed 1,000 doctors, nurses, and ward staff. So ward staff would be like nurses' assistants or people who change beds, runs with lab specimens, push wheelchairs with patients around the hospital. They were surprisingly saying that you had stigma attitudes was not stigmatized. Sometimes we find that people say what they think the researchers want to hear, and clearly that was not the case here. So we were fairly shocked when 89% of the doctors, 88% of the nurses, and 73% of the ward staff said that they would treat people living with HIV differently than other situations if fluid exposure was a potential risk. And even in situations where it was a large proportion, said that they were more likely to use double gloves or refuse taking care of patients if they thought that they might be HIV infected. So we became curious about what's driving this stigma. And the table below shows the main drivers that we found that were responsible for these stigma attitudes and for people's intent to treat people with HIV differently. So first of all, people know how HIV is transmitted. We have rarely found that that makes a difference. What they don't tend to know is how it's not transmitted. So if you have misconceptions about casual transmission, you are more likely to also have stigmatizing attitudes and intent to discriminate. If you are worried about getting infected at work, which is instrumental stigma, you're also more likely to discriminate. If you have pre-existing prejudices, negative feelings towards people living with HIV, and I apologize, this is an old slide, so it still says people living with HIV/AIDS, which is not the current term, you were also more likely to discriminate. Same thing if you blamed people for their own infection. And maybe the only positive light here is that as you have more frequent professional contact with people living with HIV, you are less likely to discriminate. So that's a negative association. So we've talked a lot about stigma, and before we go in and discuss what we can do about it, I also wanted to take a moment out and acknowledge that we are living in the midst of another pandemic right now, and that the two pandemics are not unrelated. The IAS and UNAIDS came out with statements today and noted that a survey that was done in 106 countries showed that 85% of HIV service delivery has been disrupted this year, which is enormously high. And as you remember, adherence is crucial for treatment success. So if you disrupt service delivery, we can expect to see more drug resistance and increase in mortality. And that is in fact what the modeling data are predicting. I know early in the epidemic, the slogan was, we're all in this together. I think as we have learned more about the COVID pandemic and who is being hit the hardest, we're seeing that yet again, that is not the case. Someone said, well, maybe we're all in the same storm, but some of us are weathering it in a large yacht and others may be sitting in there in a little rowboat. So same storm, very different situation, and inequities are very real. And I appreciate the sentiment between we're all in this together, but I think we miss out on opportunities to help those who really do not have the resources that some of us are privileged enough to have. There was a great modeling study by Jewel et al. Published in Lancet HIV this summer that outlined exactly how this disruption could result in additional AIDS-related deaths in sub-Saharan Africa. And I would encourage you all to read that if interested. But the barriers that they are expecting and that they are seeing are multiple levels, both individual, where people may have fear of infection if they go to the clinic, to experiencing transportation barriers, given all the restrictions, the supply chain being disrupted, so there being insufficient stock, people not wanting to take their HIV treatment because they don't have food security, people not venturing out during the lockdown and not having enough antiretroviral medication at home. Our work in India shows that following the lockdown in late March, which really was a very severe lockdown, we have not seen anything like it in the US. Our participants were struggling with restrictions like you're only allowed to travel 2 kilometers, there is no public transit available, and you can only travel one person at the household and between 6 a.m. and noon. And there were severe consequences for not doing this. So what do you do if you're going to a clinic that's more than 2 kilometers away and, where you usually have to sit and wait for half the day? So you would come home after afternoon. People reported that they would get stopped by the police, even if they had a letter that said that they were allowed to travel for medical reasons, and that the police would harass them. And they were scared to death of having to disclose to the police that they were HIV positive for the same stigma reasons that we have already talked about. So the lockdown restrictions directly impacted the severity of the stigma and made people decide to stay home. We also got reports that laboratories had to pivot and focus on COVID, which is understandable, but that may have prevented them from doing viral load testing, for example. People living with HIV who had other co-diagnoses like cancer found that they were having treatments canceled. Injection drug users reported that they could no longer go and access clean needles, which increased needle sharing. And often, in order to access treatment, you need to have a registration card, which means that you need to have an address. And a large number of migrant workers and day laborers found themselves unemployed and homeless and were no longer able to access services. And of course, migrant workers would tend to go home to the villages because they had nowhere to live in urban areas, and were far away from the ART clinic, and all of a sudden living with extended family, many of whom didn't know that they were positive, so they were afraid to take treatment anyway. So we have just written up these results and they are under review. So I think that is what that slide shows. So kind of in conclusion, in terms of the research done so far on the barriers, the good news is we've made a lot of progress. Stigma remains a barrier. COVID has made it more complicated. This is global, it's at multiple levels, and we really cannot get to these, we can't meet these treatment goals without addressing stigma directly. So how have people tried to do that around the world? Well, there have been multiple studies. Unfortunately, most of them have not been randomized controlled trials. And many of them have been funded by service organizations, so they haven't had very rigorous research component, but there's been a lot of innovative stuff done. So people have tried to integrate stigma, HIV stigma reduction in TB programs in parts of the world where they are more common, and piggybacking on their infrastructure. People have collaborated with faith-based groups, which is really essential. We didn't talk much about it, but faith-based groups can obviously either increase stigma or have a very important role in decreasing it. We have found that community leaders can be engaged in looking at this from a social justice angle. There have been a number of economic interventions focusing on training people in livelihood interventions in agricultural and financial management for people living with HIV, which had the effect of making other people seeing them no longer as useless and burdens on society, but as productive members of society, which then in turn decreased stigma. So that was kind of interesting. Many of these programs are very time consuming, especially the ones that have been done in healthcare settings. The ICRW put together a 3-day workshop that was very popular in several hospitals. But when it came to scale up time, superintendents of hospitals and deans of nursing schools, medical schools said, there's no way I can release all of my staff or all of my students for 3 full days. So unfortunately, it wasn't scalable. So we had a brainstorm or multiple brainstorms and said, well, how about if we try to make this more individually tailored? How about if we just pull out the particular activities that were found to target directly the drivers that we have found in these settings? So the misconceptions, the blame, the worry about infection, and so on. And how about if we try to make something interactive in a mobile health format? So DriSti was born, and DriSti both means vision in Sanskrit, although I'm probably terribly mispronouncing it, so my apologies to anybody who speaks Sanskrit. But it also stands for Drive Against Stigma. And this is the logo, and this is the homepage of the tablet application that we put together. It's an Android application. We did together with St. John's National Academy of Health Sciences in Bangalore and the All India Institute for Medical Sciences in Delhi, and our team at UCSF. And we have published 2 papers on the development of this, both the tech part and the intervention part. And the activities target the stigma drivers that we identified in our previous work in Mumbai and Bangalore. We narrowed it down into 2 tablet administered sessions that could be done individually at people's convenience with headphones, so nobody else has to listen to it. You just need a quiet corner somewhere for about 45 minutes twice. And then maybe because I'm a behavioral scientist, I couldn't make it totally mobile health. So we thought it was very important for people to have at least one skills training group, but it's only a 1-hour group. These are the parts in India where we worked. In 3 sites in South India, 1 in North India, and we decided to focus on nurses and ward staff, mostly because doctors are really hard to recruit and get to participate in 3 sessions and all of the assessments we wanted to do. So we started with the lower hanging fruit. The outcomes we looked at, I'm not going to go through in detail, but it's what we talked about already, the intent to discriminate in professional situations and endorsement of coercive policies. So people were presented with a set of common tasks and asked how they would perform them with somebody living with HIV. They were presented with a number of statements that related to patient rights, and asked if they agreed or disagreed. And some of them were stated in the negative, some in the positive. So do people have the right to choose to disclose HIV status? Should people with HIV be forbidden from marrying and having children, for example? So we had 17 of those, dichotomized the responses into whether they agreed, disagreed, reverse coded some. So we ended up with a score where a higher number meant more stigmatizing. And in order to be coded as not stigmatizing on the intent to discriminate, you had to say that you would treat people with HIV the same way as everybody else. And we assessed this at baseline, immediately post-intervention, which was 1 month later, and at 6 and 12-month follow-up. Our first session had 4 modules where we had an introductory video defining stigma. We did what we called a virtual walkthrough, which I'll show you a picture of in a moment, similar to Google Street View. We went over beliefs and attitudes. It was interactive, describing stereotyping, judgment, empathy. And then we had videos by people living with HIV that told their own stories, because we think it's really important that people get names and faces to put with these stories. So this was the virtual walkthrough, and people could walk around the hospital and click on all of these settings: the inpatient ward, the maternity ward, the OR, the registration room, and a video would pop up that would show a stigmatizing interaction followed by an interaction that was not stigmatizing, how it should have been done. And these are just some screenshots from there. The second session, we reviewed what we had talked about in the first session, went over transmission misconceptions, fears and behaviors, because we also need to have empathy for the healthcare providers. They're, you know, firsthand, most of you are healthcare providers or will be. You're not bad people, but when you're afraid, and you're afraid of the unknown and of a potentially very serious consequence, most of us would probably consider taking steps to protect ourselves and maybe not even pay attention to how that would be perceived by patients. So we went over that in a very compassionate way and talked to them about how they can, by applying standard precautions, take care of themselves while still not discriminating and stigmatizing their patients. So the first paper, outcome paper, came out in March this year on the 6-month outcomes. And we were very happy to see that we did make a difference. I can make the paper available to anybody who wants it. I don't know if it's open source yet, but I will certainly send it out to anyone who wants to look at this in more detail. But the good news was we reduced the barriers that came from the stigma drivers. So we reduced the infection worry, we reduced misconceptions. This was among the nursing students. We reduced the stigma outcomes as well significantly in the intervention group compared to the control group, both the endorsement of coercive measures and the intent to discriminate. Among the hospital ward staff participants, similar findings. We reduced the misconceptions around casual contact. We reduced their worry about infection in professional situations, both low-risk ones and high-risk ones. And we were happy to see that reduced their endorsement of coercive measures and their intent to discriminate compared to the control participants. So once the intervention was over, we offered the intervention to everybody in the control group too. And my final slides here deal with, we were curious about why did this work. So when we looked at the 12-month data and the findings were maintained at 12 months, we were happy to see. We wanted to know were these changes actually mediated by the reductions that we saw in the drivers? And they were partially, not fully. The intervention had some direct impact, as you can see in this figure. So this is all for nursing students. And this is in terms of how the intervention impacted their endorsement of coercive measures, their agreement with all of these policies that would violate the human rights of the people living with HIV. So reductions in blame, reductions in the pre-existing prejudices towards vulnerable groups, and the reductions in transmission misconceptions all partially explain some of these reductions in the stigmatizing attitudes we are seeing. And similarly, for their intent to treat people living with HIV differently, we see that reductions in worry about being infected at work and reductions in symbolic stigma or pre-existing prejudices towards vulnerable groups both helped explain their changes in their practice, their intended changes in their practices. So we were very happy to see that we are at least on the right track with the drivers that we were assessing. So what are we going to do next? Well, the tools that we developed for this tablet-based Android app, and I should say that the reason we used tablet-based app was because we wrote this grant probably about 7 years ago when most people didn't have smartphones in low middle income countries. Now they are way more common, especially among healthcare providers. So the next step for us is to adapt this intervention to a smartphone app delivery, and we are piloting it with medical students in India. And it's, as mentioned earlier, it's being scaled up in Thailand for healthcare providers. So we see the next steps as being about scale up both to different populations and different formats. And it still is only an Android app. Most of the rest of the world doesn't have iPhones, but I would imagine that for programmers, that shouldn't be a very hard adaptation to make. So thank you very much for hanging in there and listening, and I look forward to hearing your questions.
Thank you, Dr. Ekstrand. That was a great talk. So I think let's start with questions from the audience.
Okay.
If you'd like, you can drop them in the chat box, or if you want to raise your hand with that function, either is fine. All right. Well, I have a question. So in intervention, so there's obviously going to be some variability in between, the overall on average, it was effective. But then how did you make people receptive to receiving the intervention? And if people weren't receptive, how did you move them into that receptivity?
That's an excellent question. And I think you can use both carrots and sticks. So for the study, we pitched it as something cool and new and something that would help them protect themselves while offering better patient care. So we tried to present it as a win-win, and a lot of people, it may have less of a coolness factor these days, but back when we started doing this, I think we started implementation probably about 5 years ago. It takes a while to develop these. People still thought it was kind of cool to be doing the app, and I wish I could have shown you the virtual walkthrough, because Google Street View is a really nice way of being able to put people right in that environment and explore. And people actually were curious, because most people weren't aware of what they were doing, that it was discriminatory. So we did a lot of focus groups with people living with HIV before we started this, to find out what the actual situations were. And then we wrote scripts, and we had okay, so this is the stigma of actually making these interventions. We're going to use staff at the hospital first to act out these things. And we're shocked to find out that many of them had been forbidden from their families from acting in these roles, because the families didn't want them associated with anything that had to do with HIV. So, we used some students from different drama schools, and we used a few brave staff members. And a lot of my staff, who had absolutely no acting background, ended up acting these out. But one of the things that we found really powerful was when we had people living with HIV telling us about the situations where they felt discriminated against in the hospital. And when we told hospital staff, they were shocked. So for example, one participant said, you know, when the doctor comes in to the room and does the exam and touches me, as soon as they're done touching me, they go and wash their hands. It's like they feel I'm dirty. And of course, we all know that infection control is so important, and you're supposed to wash your hands between each patient. And the fact that they washed their hands afterwards had nothing to do with thinking that the patient was dirty. So we said, well, since you don't mind washing your hands a lot, how about if the first thing you do when you come into the room, before you touch the patient, is wash your hands? And then you can do it again before you leave the room. And maybe that'll be overkill for you, but it'll tell them that you consider yourself to be just as dirty as they are, and that you want to protect them. And it'll send a completely different message. And they were so happy to hear that, because nobody wants to make their patients feel uncomfortable. So we were able to come up with a lot of very practical suggestions like that. And I think partially through word of mouth, maybe that spread, and people thought it was kind of a cool program to learn about stigma and learn how to protect themselves. So we didn't really have a problem recruiting. Now I know that once it gets scaled up, it may become more of a requirement. So in Thailand, for example, they are making it mandatory for all healthcare personnel to go through a stigma reduction intervention. So that'll take care of it in that setting. And I would imagine if something like this gets implemented in medical schools and nursing schools, that would be the same thing. So.
Yeah, and that makes sense for, you know, in terms of timing and effectiveness to make it, well, not just mandatory, like we all have sexual harassment training and all these other things, but it also seems like to have them cohort with their co-students as well. And I do have another follow-up question, but I will wait and see if anybody from the audience would like to ask a question before I ask another question.
Yeah, I've got a question. Hi, Maria. It's nice.
Hi, Mark.
I'm curious about family stigma. In other words, in my clinic, I have a lot of young African-American men as well as other ages, and there is a great deal of stigma. It's not unusual to be told that absolutely nobody knows about their status, or that almost nobody knows about their status. And I wondered if you're aware of any interventions that are getting done to attempt to counteract family stigma.
Yeah, unfortunately, I think you touched on the Achilles heel of stigma reduction programs. Families are the hardest to deal with. In our adherence studies, we always offer to co-facilitate the disclosure to their family members. But most of them don't take us up on it. They don't want their families to come in. They don't trust that once they find out that there won't be consequences. So it's hard to reach the families if you're not allowed to disclose to them. So most programs seem to attack that more through community-based stigma interventions, through popular media, like having people living with HIV become characters in soap operas. I know that's been done in Mexico, for example, street fairs and street drama in both India and in Southern Africa, but more media campaigns in general, because outreach to families is so very, very hard. And when we ask people living with HIV to name the two sources where they're most afraid of stigma, it's families and healthcare facilities. So there's definitely a gap there, and anybody who wants to take it on for a research project, the field's wide open.
Aside from the difficulty of engaging family members, do you think that there are components of your intervention that could be adapted to those? I mean, aside from the engagement issue.
Yeah, I mean, but it would probably not have to at least overtly be targeting them. You know, it would need to be more community-wide, because as healthcare providers, you know, we are so aware of the fact that we can't cause harm, and we are scared that we may put our participants at risk. I mean, before we call anybody, we have lengthy protocols for if we call you from the study to remind you, you know, what if you have a shared phone, or if somebody else picks up the phone, what should we say? Our interviewers have a long list. Interestingly enough, the two most common things for our rural participants when we go and do home visits, if they have authorized that, is to say either that we're from the census, or that we are with a life insurance company, because apparently representatives from life insurance companies come and knock on people's doors all the time. So one time, one of my staff members did that. They were knocking on the door of a participant, and the neighbor came out and said, "Oh no, they're out. Who are you? I'll tell them you came by." And my participant looked at the card and said, "Oh, I'm from a ex-life insurance company." And the neighbor goes, "Oh wow, I wanted to sign up for life insurance for a long time. Why don't you come into my home and tell me about the life insurance?" And our staff was like, I'll call the office and have somebody come by later."
So much for the disguise.
Yeah. Be careful.
Yeah. Well, we do have another comment from the audience. Linda McCreary.
Maybe
Linda, you should be able to unmute yourself.
Yeah,
Now I can. Thank you. Sorry, I couldn't unmute it first. No, I just wanted to thank you for your presentation. It was truly wonderful. And I wanted to also say that for a number of years, our College of Nursing here at UIC has been involved in work with a hospital and College of Nursing in Maharashtra. It's called Bangalore College of Nursing, may be known to you, but their mission really was to provide HIV care. So they became pretty much a specialty hospital for those with HIV care needs. And then they started a College of Nursing, which was really a challenge when you want to enroll these students and their parents are quite concerned that these students will be exposed to HIV during care. But they've managed to get past that and they have great enrollments. But one of the things that they have done from the start is to demonstrate destigmatizing attitudes. They actually have made it a very strong point to include people living with HIV on their staff as volunteers on the grounds. They have demonstrated by sitting down and sharing meals with the patient population how to be destigmatizing, and their intervention with families is very interesting because they require a patient who's admitted there to bring a family member, and the family member has to stay during the duration pretty much of the whole hospitalization, and the family member is exposed to all this destigmatizing behavior. People sitting in groups chatting and sharing a meal, or people walking around if they're well enough to be out walking and stopping and chatting casually with the staff or the students or whatever. It's very powerful to see by demonstration, sort of just by role modeling, the change. And we did a small research study with the nursing students that was longitudinal. We could see over the period of time from when they were admitted as first-year students till they graduated, how their stigmatizing attitudes steadily reduced and their ability to treat everyone equally steadily increased. And when they are placed in clinical placement sites outside of Bel Air, the students themselves are powerful role models of how to give destigmatizing care and be, well, anyway, they're like ambassadors. So I just wanted to say that. I'm not sure if you're aware of Bel Air, but sometimes we can do a lot just by our example.
Thank you, Linda, for that other example of how to reducing stigma in the healthcare worker setting and how that can then relate to families that get that secondary exposure in that setting. Dr. Ekstrand has lost her connection, so unfortunately, I don't think she was able to hear the end of your comment, and I don't know. We'll see if she'll be back. So I am sorry about that. I think she will probably try and come back, but I know that her sound was getting broken up towards the end. So I think she was having some connectivity issues. Since Dr. Ekstrand is not here, I think we will move on to the breakout sessions. And if you have other questions though, please put them in the chat box or email it to me or Chelsea, and we will forward those to Dr. Ekstrand so that she knows your questions. If she does come back at some point, we will let you know. But otherwise, I think let's move on to the breakout sessions. And do Drs. Dworkin, Rosano, and Lofton, are you okay with that? Are you here? I see Rosano, I see Dworkin, and the way, let's see, is Lofton, and Lofton is here as well. All right, so we have our breakout session moderators. And thanks everyone for attending Dr. Ekstrand's talk. And I really appreciate your time and efforts towards HIV prevention and care. And I see there's a question on a copy of the PowerPoint and the article. The article, she said, yes, we'll have to ask her for permission on the PowerPoint. However, we did record this talk. So even if we don't have the PowerPoint, we'll be able to share the recording. So, okay. All right, well, thanks so much everyone, and enjoy the breakout sessions.
Okay, I just opened the room, so you should all be able to move into your break.